Welcome to session number 3 of Sleep Matters. This session is entitled The Treatment of Sleep Challenges, and will focus on strategies and lifestyle changes that support the interventions of challenges of sleep across the lifespan. We're going to start off our conversation talking about babies and supporting babies with sleep and their sleep processes. New parents know this is a dramatic lifestyle change, especially if you're a first-time parent, in understanding the cycles and rhythms of a baby's sleep. And it's very tough often for new parents who just need a few minutes to themselves or some rest themselves. And new babies, especially very young babies, just need to be held. Neurobiologically, the closeness of a baby to a caregiver's body regulates the baby's immune system, regulates the baby's neurochemistry, neurotransmitters, regulates the baby's microbiome in their gut, and regulates the baby's stress response. So it's biologically optimum for a baby to be close to their caregiver. And did I mention that parents automatically adjust their temperature to bring the baby's temperature into the just right zone of body temperature regulation? So when you hold your baby, he feels your warm body, hears your heartbeat, can smell you. It feels like being inside the womb. And this is a sense of safety and regulation. Babies sleep in utero, and they can only do that when they feel safe and secure. So in a newborn, early infant development period, sleep depends significantly on safety and security and the ability for the baby to relax in their body. Babies are not capable of maintaining a consistent schedule, darn it, until they're about 4 to 6 months of age. New parents might not find this easy, this adjustment. The first few months of a child's life is not the time to set up a rigid routine. So the idea of having an early infant on a sleep regime is not physiologically compatible with the neurobiological design of that baby. For newborns, napping and feeding is on demand. And this is often an adjustment that is not easy to make. I'm not going to speak much here about maternal depression or postpartum depression or difficulties in this regard, because that could be its own workshop. But please know that those goodness of fit variables impact the ability for this dance to respond in a regulatory and comfortable fashion. I'm using a new word here to replace cry it out or behavioral approaches. The literature here is vast, and the most common wording that I could find is called unmodified extinction approaches. And I have a question mark here because this is not an easy conversation. Although babies can learn to be trained, I would like to recommend that parents be trained, that babies can learn to inhibit the display of their discomfort and distress. They can learn how to do that as early as 2 weeks old. If I leave a baby unsoothed, I'm thinking about all the work that I have read about and my personal experience in orphanages. Babies can learn to suck it up, shut it down, and inhibit the display of their discomfort as early as 2 weeks of age. So there's a very big difference between a calm, regulated shift into a sleep state and an exhausted, dissociated, shutdown state. So this is a tricky conversation for me, given that my personal focus in my work is around attachment, co-regulation, feelings of safety and comfort. Recommendations often caution parents against responding to their babies when they transition to sleep or wake. There is this perception, and this came from Dr. Spock way back when I was a child, 50s and 60s, that babies can be trained to not need their parents for these transitions. And that could in fact spoil the child. Well, literature now tells us that's not accurate. You can't spoil a baby because they are responding from physiological contingencies. So I would say the focus is upon limiting parental presence and response to infant signals for attention during transitions to sleep. That's the cry it out. The Ferber method is limiting your response so that the baby has to get it together on their own. So these practices include crying it out, decreasing parent response to infant crying, and then fading routines of comforting and attentiveness to crying across time. There is a tremendous amount of conflict, as you can imagine, in the literature of the long-term outcomes of this. And this has created such stress, this conversation, in workshops for me around the globe for the past 15 years. Because this conversation creates so much guilt in parents who have followed this idea. I want to tell you a story right here. I was speaking at a conference, and like I do, and I had a particular physician become enraged. He was a participant in my class around the idea of the physiology of regulation in transitions, co-regulation in transitions between sleep and wake. And I was talking about that in as non-judgmental a way as I know how. And this particular physician started to scream at me in the middle of this workshop with a lot of passion. And I guess I must have held space in a good enough way, because at lunchtime, this gentleman came up to me and said, "I want you to know how sorry I am for our conflict in class. I had a 3-year-old child with a significant chromosomal abnormality, developmental disability, who just passed away and never slept for 3 years. And what happened to me in that conversation is I got so activated with guilt because we left her so much to cry. And it's already making me feel so uncomfortable just thinking about our experience with her." So I will never forget that story, because the last thing that I intend in this part of the conversation is to engender any more conflict, trauma, guilt. I'm presenting this to you from a place of consideration and possibility and not judgment. Hopefully, you'll take that in. What does the research actually say? Whether parental responsiveness when infants transition to sleep is helpful or hindering is actually a controversy. We don't actually know. The debate is about the role of the parent's responsiveness as the infant's regulatory system develops across time. So one of the things I want to say here is, in an attuned state, you can actually tell with the sound of the cry, with your feeling of your own physiology, if it's a shift into a down-regulated calm or a shutdown. Because the cry of true distress is so high in pitch and volume, and the baby is so out of control, and then it'll stop. So what I'm recommending is real attunement and an intuitive sense of what does my individual baby need, not what does a protocol tell me to do. And whether the infant and the parent's sleep quality has benefited or been hindered by the parent's presence also remains unclear. For me, separations are so significant to regulation of the self and arousal. And measuring sleep across time may not be the variable you want to look at. You know, does my baby have sleep problems in the future as a child or a youth or an adult because I left them to cry it out? Might not be the right question. Might be more about, how does it show up in relationships? How well do they manage their anxiety? These are the kinds of questions that have not been studied to a great depth that I can see. I'm interested in looking at this deeper in the future as a standalone conversation. Sleep as an outcome of co-regulation in infancy. So my preferred form of support, I'm going to use that word, is called response-based sleeping. Not attachment sleeping, not spoiling your child, responding to the child that you have. A lack of response to infant cries at night, or being inconsistent in responding between day and night signals, has been shown in this beautiful study in 2017 to increase cortisol in infants and create stress responses that take that baby outside of their window of tolerance. So teaching parents to understand and to respond to the cues has increased what we call total sleep time for infants with problematic sleep. This was such a beautiful article about how to support parents in being more attuned and how the outcomes of that attunement across time changed the length of time that that baby stayed asleep during both the day and at night, and created a greater depth of sleep, which is a signal of health, as you know, and hygiene in sleep. So this article had a big effect on me as the relationship between attunement and sleep quality and sleep time. Mother's emotional availability at sleep time was related to fewer times that they then had to return to the infant at bedtime or during the night, during awakening. So the mother's sense of availability. I wish I had known this stuff when I was a parent, when Lisa was little. The parents, I'm speaking about myself personally, both mom and dad can have their own response-based sleeping pattern. There can be one related to mom and there can be one related to dad. So the mother, who also is the feeding parent typically, that's part of the emotional physiological availability to the infant. So the mom's availability at bedtime and the amount of soothing over time decrease the amount of waking. And this is a tall order if you're exhausted. It's a big job to stay emotionally available when you're exhausted or when you're preoccupied with some other aspect of your own distress and suffering. This offers an infant an experience of parental comfort during transitions to sleep through the parent responding to the cues and the behaviors. And when we think about this, you can only regulate another if you're regulated yourself. So you can see how these cycles, and this is what causes parents so much guilt. Because when I say stuff like, you can only regulate another person if I'm regulated myself, if I'm dysregulated, we know how it impacts our kids. And that can create a sense of internal distress, which can feed on itself. So it's important to remember also, for self-regulation, I need self-compassion, kindness to myself, reminders that I'm doing the best that I can with what I have. These are all parts of the whole process of being a response-based process. I had the opportunity to read many books around this topic of sleeping and infant care, and saw many, many websites. And this is my personal favorite. It's called The Happy Sleeper, science-backed guide to helping your baby get a good night's sleep from newborn to school age. And because one of my heroes, Dr. Daniel Siegel, wrote the foreword, that gave me a little more confidence that this was going to be about co-regulation. So The Happy Sleeper by Heather Turgeon is a highly recommended book about parents' consistency and their attunement in supporting their children's sleep. And the book walks you through all the different ways to attune. And it broadens the depth of this conversation that we're having right now. Co-regulating for sleep in infancy also involves what I do with you physically. And to initiate a baby's ability to begin to shift towards sleep, I'm reminded of Harvey Karp's work, The Happiest Baby on the Block. And he talks about swaddling, moving, making shh sounds. That there are physiological, sensory aspects to this process. Very soothing to a young baby because it reminds the brain of the in utero experience. Rocking, singing, stroking, until the child settles down. And many parents that you see do this intuitively. And very young babies don't yet have the ability to calm themselves. Many of the children that occupational therapists work with, who have neurodiverse brains, prenatal exposure to drugs and alcohol, they will have even more difficulty with this transition I keep using the word transition because transitions are stressful, especially transitions that involve separation. So this from the caregiver. So this length of time that these sensory supports are going to need to happen will be variable, dependent on the child that you have. Putting your mind in the mind of the child that you have in front of you. Not following a list of things that you have to do, but being able to tune in and find a goodness of fit between the caregiver and the child. And when you have a orchid brain, sensitive brain, or a dandelion brain, a seeking brain, you may need a translator, a therapist, to help the parent understand, why is what I'm doing not working? Why is it every time I smile the child freaks out? Why is it the way that I pick up the child when they're sensory sensitive, that they arch away? Our role as helping through psychoeducation parents understand these behaviors can create the goodness of fit that's important for these physiological co-regulators. We'll just go from one controversial topic to another. Co-sleeping. You know, there are so many cultures that would think we are goofy, even doubting that this is something that is positive to do. So it's a very hard conversation to have. And so what I'm going to say is the decision to co-sleep with your child depends on your beliefs and your values, and is not, again, something that is set in stone from a neurobiological, physiological state. Historically, babies slept with their caregivers, and we survived as a species. So it's a very interesting conversation to have or not have. However, in my lifetime, sudden infant death syndrome has become a conversation around co-sleeping. And what I discovered in my research is that there are different causes and different types of sudden infant death syndrome. So here are some of the risk factors. Prone sleeping. Part of this, we think, is because the infant diaphragm is not very well developed, and the regulatory mechanisms that regulate the heart and the diaphragm are not mature. And prone can put a constriction on that neurological interface between the cranial nerves and the heart and the diaphragm. So prone has been shown to create a potential challenge in very young babies in compromising their respiration rate in sleep. Maternal smoking. And I can't tell you why, but when you look at all the literature, there is a higher number of children who are at risk for SIDS if mom was a smoker throughout her pregnancy and post-delivery. Soft bedding for the child in their crib or in the bed where they sleep with their caregiver seems to be a variable that can contribute to suffocation. So a meta-analysis is when an author looks at as many papers as they possibly can and then analyzes the data across literature, found that co-sleeping itself is associated with an increased incidence of infant death, even in the absence of other risk factors. And what that means is there's a higher incidence of infant death in co-sleeping situations than not. So that is the variable that makes this conversation controversial. And 2-to-1, males to females. So twice as many boys are likely to die of SIDS than girls. And we know neurodevelopmentally that the male system is more vulnerable to multiple factors of neurodiversity, of challenges with development in general. However, this one study, sleep is hot. And there are so many new studies. So you don't have to go very far back in time to find very exciting information. They found that there were different kinds of SIDS, 2 specifically. And one way that they did this was by looking at postmortem. And they is Collins Prano and colleagues in both Denmark and Australia. And they looked at the brains of babies that had died of sudden infant death and looked at the conditions and the variables in that baby parent's life. So they stained the brains after death. I know this sounds gross, but it's an important part of our research. And they looked for, you've heard the term amyloid plaques before in dementia. But these are, amyloids are disruptors in the health of the brain, in the health of the brain networks. And that they found these proteins that are going to create problems in glial cell, neuronal cell communication in babies with sudden infant death syndrome. Axons were disrupted. There was injury in the axonal transmission. And they found that there was a very big difference between infants who died sleeping alone to those who had died in a shared sleeping situation. That there was a significantly higher amount of these amyloid precursor proteins in the alone sleepers than those who died in co-sleeping. It's like, and I hate to say it this way, but there was something wrong already in the brain, sitting behind the scenes, that potentially could have contributed to this unfolding dysregulation that resulted in death. Whereas co-sleeping babies more likely were asphyxiated by their caregivers. And that there was underlying brain etiology in sleeping alone babies who died during their sleep. So this is an important differentiation. Both are called deaths of babies, but one seems to be more brain-based driven, and the other one seems to have some contributing factors to the environment in the co-sleeping context. Whenever I have to talk about something uncomfortable or controversial, I like to read as much as I can so that I feel like I'm understanding things as best as I can. And this is a great book I found called Safe Infant Sleep. And it's a really beautiful, it gives parents a lot of comfort. Is if you choose to co-sleep, how best to do that. so that there is a safeness as best as you can to that process. Thank you, James McKenna. And he did such a significant amount of research in the lab on sleep studies in babies who were sleeping with their caregivers. There are many bedding options that help or address this issue for people who want the closeness but don't want the fear. And this is a nice example. So, how do we protect babies from sudden infant death? Number one, babies should not share a crib with another infant, nor sleep in a bed with adults, because what we have heard and what is common in the literature is that babies are suffocated by other people or other entities in the bed with them. And this is more common when there is alcohol abuse by the caregiver or a parent who has been breastfeeding and perhaps has fallen asleep and suffocated their child with the breast. These are, again, very difficult topics to talk about. They are accidental, but they are part of that safe sleeping thought process. Put baby to sleep on their back as often as you can. And as a neurodevelopmental treatment instructor, I know that tummy time is really critical to the development of musculature. So if you're a parent that is worried about having enough action in prone for optimum development, give that child tummy time when they are awake and supervised. Never place babies on a waterbed, a sheepskin, a comforter, a soft sofa cushion, or a place where they could suffocate in the cushiness of the material. Remove stuffies, stuffed animals, pillows, thick, fluffy blankets from the crib or the baby's sleeping area. Avoid exposing babies to secondhand smoke, exhaust, wood smoke, air pollutants. These have been variables that can impact the respiratory system of especially very young babies. Limit babies' exposure to people with colds. Oh boy, this is a hot topic right now given COVID-19. We have, in our Arctic of Canada, there's such a high rate of babies who end up with very serious respiratory infections, who, because of the closeness of quarters and being indoors with so many people, that this is a common factor that we see in infants who live in confined spaces with lots of people. Dress babies in light sleepwear. Don't let them overheat. So often we're worried about them being warm enough, whereas in fact we might be thinking about, are they cool enough? Use a thin blanket tucking from the bottom half underneath of the mattress, and don't make it too tight and constrictive. Have the mattress, if you're going to have a crib, be firm and allow that baby to have mobility on that space so that they can move to some degree on their own. So these are 9 suggestions that came from multiple public health supports, but this came from, a standard poster that you might find in a public health office. So now baby is growing up a little bit and has a greater degree of physiological self-regulation. At about 6 months of age, babies are more acutely aware of separations, consciously. Physiologically, they were aware already, but now consciously, they don't yet have object permanence. So when you walk out the door, they're not actually sure you're coming back. And this makes transitions to sleep tricky for babies between 4 to 8 months range. So there are a few things that can help. Preparing for the change by making the room that they're going to sleep in safe and familiar. Spend time in there when they're not sleeping so that they feel connected to the space, comfortable in the space, that there's no, they realize contingently that it's their space. Read in there, play in there. Don't be afraid to make that sleeping space a multi-purpose safe space. Use their new bedroom for diapering, nap time, as well as bedtime. Start naps during the daytime for a few weeks, and then transition to nights. Give them that sense during the day, because nighttime is when separation anxiety is always the worst, because it's dark. And so that's very important. The darkness creates a sense of increased anxiety for many babies. Nighttime sleep is always a more difficult transition. Establish routines. Routines, and keep them consistent, because routines create structure, predictability, consistency. The brain loves it. Decreases cortisol hugely to know that this is what we're going to do every day across time. I say it that way because I'm not sure that's my favorite. I love novelty. But children need routine. That quiet play, bath, pajamas, teeth, potty, story time, bed, water, song, hugs and kisses, lights out, good night. And that this is done with an attuned space, without a lot of negotiating, navigating. How we regulate our children during these activities is part of the behavioral approach, if a lack of a better word, how we are. And so kids with sensory sensitivities, for example, don't like having their teeth brushed. They don't like some of these activities. They don't putting their pajamas on. If you have a motor planning problem, putting your pajamas on could be a terrible part of your experience. So you might have to tease out particular aspects of the routine that are a dilemma for the child, and perhaps create more support or less support during those particular variables. A National Sleep Foundation poll found that infants and toddlers who were put to bed asleep were nearly 3 times as likely to wake up. So if I put you down when you're already asleep, you didn't experience the transition. And when you wake up, you're freaked out and more afraid than if I was awake, I co-regulated you to sleep, I left the room, then you wake up and you feel, I learned that my caregiver was here. This is part of the object permanence. And I'm going to be safe and okay. But it's startling to a baby if you're sleeping in my arms and then I wake up alone. So they found an increase in awakening in babies who didn't have that support during that transition. That's part of the happy sleeper. How do we help with nightmares? With children, nightmares require heightened levels of co-regulation. And what can happen is that if the child had difficulties with co-regulation during the day, and all of a sudden they get co-regulation for a nightmare, then that can be a contingency that gets reinforced. So that's what we mean by a behavioral experience. If my connection, putting my mind in my mind of the child, in my waking time, is low in availability, and I'm more available when the child has a nightmare or a terror, that may be where we meet. And so then the child's system unconsciously learns that when I'm afraid or when I'm dysregulated, my caregiver is there for me. This is attachment. So the important part is across the child's life in their early infancy that helps them translate that into how they manage their own fears in sleep and in waking. Now, working with clients with post-traumatic stress disorder, it is important to help them in a different way. Now, when I think about people with trauma, re-experiencing their trauma, having recurring nightmares is part of post-traumatic stress disorder. And many, many, many clients learn to manage their day life, and the last thing to change is their sleep. And so one technique that has been demonstrated, ironically, to be very effective in changing what's going to happen in my subconscious state of sleep is called imagery rehearsal therapy. It's a form of cognitive behavioral therapy. And it takes consciousness in the daytime. Begin by imagining a dream you'd like to have. You can imagine any dream you want. Don't think about your nightmares. Think about a different dream you'd like to have. Write it down. And every day, take a few minutes to think about that dream. It's like you're planting. It makes me think of the movie, I love this movie, called Inception. Makes me think of Leonardo DiCaprio in Inception, where it's almost impossible to tell the difference between my life in sleep and my life in wake. And how there is this belief that I can change my mind and my brain with consciousness in the daytime, and how that's going to impact my sleep. I think of it as almost a form of meditation. In this research, which was reported in the Science of Sleep, these patients, clients, reported 40% less PTSD symptoms, such as shame and emotional numbness, that this kind of active rehearsal in their mind really allowed them to, it activates the right side of the brain, brings online through that left. The left is the language, the positivity, and the left brain soothes the right brain, and then the right brain soothes the amygdala. And so you see a change in this overall sequence of trauma loop taping in the nervous system, both in the daytime and at night. So this is a very cool, but when we talk about strategies are different than tools. Strategies are lifestyle changes. Tools are products. And we are a society who likes to take a pill and just make it be different. Strategies take effort. It takes effort to change your brain. It takes effort to change your life. So these strategies for shifting sleep, they often take consciousness on our part to make that be different. We're going to move along from children to youth. Interesting. When I was a teenager, we'd have a bedtime regime for during the week in school and a different one for the weekend. Well, everything that I've read for both teenagers and adults is that we got to have the same bedtime all the time, which, isn't always easy to do because we always like to do things differently on the weekend. But every time, this is interesting, we stay up later and get up at the same time, or go to bed later and sleep in, we have what we call social jet lag. It's not time zone jet lag from flying. It's social jet lag, that's what they call it, where I haven't stayed in my circadian rhythm. And this changes your hormonal system and is not, if you have an already existing sleep problem and less resilience in your bandwidth of your sleep, you're going to find this hard. If you have a lot of adaptability, you may be okay. But kids, teenagers who already have so much load in their nervous system in navigating their sleep-wake cycles and their self-regulation because of all the growth that's happening inside of them, sleep is one of the first functions that is hard for them. Caffeine, whether that comes in the form of Coke, not cocaine, as in Coca-Cola, or coffee, none after lunch for the adolescent nervous system because the caffeine-adenosine ratio in teenagers is different. There's a higher level of endogenous sensitivity in teenagers. Limit screen time. The hardest one. You're going to hear me talk about blue light in session number 4 and what that does to the brain and how we can change that. And limiting screen time in the evening is very important for transitions to sleep. And so many of our kids fall asleep with this in their hand and, are still talking to their friends well into the night. Putting your phone on airplane mode so that it doesn't ding and wake you up. I learned that actually from Bob, not from reading adolescent literature. Relaxation time before bedtime. Reading a book, having a bath, doing something that nurtures you before bedtime. Advocating for later school start times. This is happening across the world in various locations where teenagers actually go to school at a later time than you might if you're in elementary school, especially at middle school, which in our country is grade 7. And remember, the adolescent brain needs more sleep. So try as parents not to shame our kids for sleeping more. It's just part of their physiological need in order for them to be their best self. Lots of studies, but especially by OTs, which is kind of cool, have looked at college students and sleep in this highly stressful time. So Megan Chang, who is an OT that I deeply admire, she looked at college students and all the conditions surrounding their sleep. And she found that in her study that her college students who had positive self-regard, positive self-talk, had better sleep quality. Whereas the individuals who had negative self-appraisal were in denial of their feelings, they sucked it up, engaged in substance abuse, were self-blaming, and did a lot of venting about their experience in college, had significantly less qualitative sleep. Even though they got exercise, they were able to control all of the variables that we just talked about. They didn't drink a lot of caffeine. It was their mindset that she found to be the biggest variable in the capacity to sleep, which just reinforces how important anxiety is and managing our anxiety if we want to sleep. And being in college, university is such a significant, stressful time that, and we also learned that you consolidate all your learning when you sleep. So it's kind of like being on a hamster wheel, as we say. I think I need to stay up later, work longer in order to be able to cope with this volume that I have to accomplish, which actually makes me learn less. So it's a very vulnerable time to shifts in sleep capacity that can sometimes last after college is over, well into your work life. Very important study. I recommend this reading. There's a term typically used, and I just think about this book by Matthew Walker. It's kind of like the Bible of sleep. I was on a Zoom call with my family, and my stepmother-in-law said, "Kim, have you read the book by Matthew Walker? It changed my life on why we sleep." And Matthew Walker talks a lot about sleep hygiene, which are the habits that we have in our day life, just like infants, that are important to the quality of our sleep. Our routines, our exercise, our food, our self-care in the day contribute significantly to our sleep. Now, Matthew Walker talks a lot about the concept of catching up on sleep. And he says in his book, sleep is not like a credit system in the bank. The brain can never recover all the sleep it's been deprived of. You cannot technically catch up on the sleep that you missed during the week on the weekend. That you may feel better in the moment, like if you are sleep deprived all week and then you sleep in on the weekend, you'll feel better on the weekend, but it actually doesn't physiologically undo the harm that, I'm trying to say this to myself, that happened during the week. And so all of that washing machine function that is needed is not, it's not like, okay, I didn't do a good job, Monday to Friday, so now on Saturday and Sunday, I'm going to clean up my brain in a good enough way, like I did, as if I did it every night. And the reason this matters is because Matthew Walker is looking at things like Alzheimer's and long-term outcomes of sleep deprivation on the brain. One thing, though, that can happen is you can change your insulin when you catch up on sleep. Now, one of the things we talked about in earlier sessions was the connection between sleep deprivation and obesity and weight management, how sleep is a very big part of your metabolic functions. For if you're trying to lose weight, you've got to sleep well in order to do that effectively. So you, who is such a sleep guru, he brought chronically sleep-restricted people into the lab for the weekend and had them log in 10 hours of sleep in their catch-up on the weekend. And what they did show improvements in was their ability of their insulin to produce blood sugar. So this is very important for how you manage your metabolic functions. And it suggests that catch-up sleep may undo some, but certainly not all the damages that sleep deprivation causes. So this gave me some encouragement that adults who don't get their regular 7 to 8 hours a night, that they at least benefit in their insulin production when they do get a good night's sleep and catch up on the weekend or when they have jet lag. I had a thought of clarification here of the differences between the word produce and process. So I talked a moment ago about the production of insulin, but in fact, what sleep contributes to is the transition from insulin to glucose. And so that it helps in the metabolic process of how we are going to use the energy that we get from our food storage through a greater effectiveness of our insulin. So I think that is an important depth of clarification of the specifics of what happens to insulin production and the outcome of that insulin production in its capacity to process blood sugar. Another aspect of sleep hygiene that both Matthew Walker and the Science of Sleep by Time magazine talk a lot about is not pressing the snooze button. This applies to so many. When you get a solid 8 hours of sleep and you doze off for a few more minutes after the alarm, it actually makes you more drowsy and less aroused for the long periods of time in the day. It's kind of like you've taken your sleep cycle out of its regime, and it leads to this grogginess, and it has an actual name. It's called sleep inertia. It has an opposite effect. It impairs alertness, memory, reaction time, and it creates the impression that you got less rest than you did. So that temptation to just, another 5 minutes is really not a great thing. Alternately, it's also not a great thing to just jump out of bed. It's a transition. So it's awake, and you adjust to the wakefulness state, and then get up right away. If you snooze because you're so tired and you can't peel yourself out of bed, something else is probably wrong. So very important. And one of the things when they study sleep apnea that is a question on the questionnaire, one of the questionnaires that is so famous is called the Pittsburgh Qualitative Sleep Test. It's used in almost every research study, and it's this plethora of questions about your sleep hygiene and the quality of your sleep. And so this is a big issue in measuring sleep regimes. How often you press the snooze button on the alarm in the morning. Alcohol. Alcohol makes you feel drowsy, but it's bad for sleep cycles. And a lot of people in my work with addiction, a lot of people, including my friend Theo Fleury, would tell you that many of them drink excessively in the evening to try to fall asleep. Because sleep is such a connection to the trauma that they may be trying to avoid as a part of their coping strategy through their addiction. But the brain waves of those who drank before bed had more delta, which is associated with deep non-REM, but also more alpha, which is what you do when you're awake. When you're kind of in that mindless, inattentive space, this can lead to more of that hypnagogic experience where you're like not really sleeping. So you've got this mixed message in the brain of low arousal depth of sleep and high activity, wired, but not sleeping properly. So the benefits of falling asleep quickly from the alcohol are disrupted by this alpha wave presence. So you, in effect, are really, really tired, but really, really wired. And so alcohol before bed is not a helpful sedative process for the sleep transition. Interesting. The moon and sleep. And there is factual information around the moon's impact on our circadian rhythms. Current biology reported that study participants who slept in a completely dark lab got an average of 20 fewer minutes of sleep per night on the days around a full moon. So around a full moon, there was less sleep. That's certainly part of my experience. And that they had lower levels of melatonin and 30% less EEG activity in non-REM phase. So this monthly anomaly is ingrained in our circadian rhythms. That when there's a full moon, our sleep is not as comfortable as it may be in other times in the monthly cycle. How we develop our resilience in our days, in our life, affects our sleep. And speaking right now in COVID-19, this is one of the hottest topics that the Relationship Matters team speaks about every day to diverse audiences, is about resilience. And resilience is about how I bend and adapt and move and allow myself to be in my life as I face the challenges that I do in my life. So the question I ask here is, what do you do with your thoughts? I think about this beautiful image of these rocks that sit in the ocean with the waves crashing on them. They just sit there and the water hits them all the time and they don't move. And they erode and they experience weathering, but they stay there. They stay in place. And so how we manage our lives helps us manage our sleep. Cognitive behavioral therapy and sleep is actually very important because what cognitive behavioral therapy means is thinking about what I'm doing, being conscious. There's compassion-based cognitive behavioral therapy, which is what I do with my mind and how I treat myself. So a lot of the research in insomnia, specifically insomnia, comes from the CBT literature, which helps you establish routines. Just like we talked about changing the routines for babies, CBT does it for adults. It's where I have to have this regime of predictability. It's kind of like I reparent myself with my own mind. And this is the essence of CBT for sleep. So the behavioral elements support people to develop a pro-sleep routine and to imagine a strong connection between bed and successful sleep. Because what happens is you don't sleep, so you worry about going to bed. Oh, it's going to happen again. And changing that attitude, changing your thinking about it, can change the brainwave activity in relationship to the experience of going to sleep. Dr. Rick Hanson, who wrote the book Resilient, talks about how the brain is designed like Velcro for the bad. How our survival brain is oriented towards negativity. Our thoughts are negatively biased. And in order to change our internal stress responses and maximize our resilience, we have to become conscious of those negative thoughts and shift them to positive thoughts. So when I go to bed at night, instead of thinking about the one thing that went badly during the day, if I can shift my consciousness to gratitude practice, where I re-experience all of the wonderful things that happened in that day. These are tagged with dopamine and norepinephrine, and Dr. Hanson calls them keepers. Keepers means your brain is going to keep them. It's going to take that new neural network of a positive pathway and keep it. And keepers consolidate a thought as a lasting resource in your brain. And that's how you become resilient. States become traits. You can become a more positive being by consciously shifting your consciousness. Enjoying life is a powerful aspect of self-care. When you stand in front of a camera and talk about sleep, and you're delighted and excited, and you find this engagement process full of joy and enthusiasm, it's a keeper. And it fills your bucket instead of seeing it as depleting or negative or challenging. We create our own reality with our minds. Mindfulness has a tremendous impact on sleep. What we do with our own thoughts. Self-compassion, which is part of resilience, which is part of stress management, which is part of decreasing anxiety, is where people feel compassion for themselves. Kristen Neff, I call her the self-compassion queen. She has written many books and done many TED Talks on the process of self-compassion. And she so clearly states that it is easier to have compassion for a stranger than it is for the self. Interestingly, if I'm lying in an MRI scan chamber and I say to myself, Kim, you are such a kind person, even though that person really hurt your feelings. What's interesting is that the motor cortex lights up. And when I first read that research, I thought, why? Why would the motor cortex light up when I'm having a compassionate thought? And the reason is it gets you ready for a different action. It creates movement patterns of connection, of moving into what we call approach, which is the opposite of a stress response. This is avoidance, which happens with a negative thought. But with a compassionate thought, my body actually moves in and it softens, and the tone and the stress in the body changes. You already have a different motor pattern in your body from self-compassion. I love that. This is a form of inner strength. So we must become conscious and aware of how we care about ourselves, how we feel, and how we self-regulate. I call it being relentlessly positive. Dear me, I choose a new inner voice. I love it. That inner critic, it's been a boss for too long. So I'm going to make a different boss in there, one that is wiser, kinder, and more compassionate. And this impacts our state of arousal, which then has spillover into our sleep. Remember that arousal is the foundation of sleep. Arousal is sleep. The reticular activating system affects sleep. And for 25 years, these three circles have been in every presentation I've ever given. That arousal comes from our mind, cognition, which we just talked about, our body, our sensory processing, and our emotions, our attachment. So in this conversation thus far, we've talked about co-regulation through relationship, which helps with the emotional management of arousal. We've talked about cognitive behavioral therapy and self-compassion, which manages the cognitive component of our arousal. And now we're going to talk about sensory. What do I do with my body to manage my arousal states, which will impact my sleep? So I went to the OT literature to look at sleep and kids with neurodiversity. What could I find? And I found a few things. And so Gila Spira looked at a population of Israeli children, and she found that sensory interventions were helpful in improving sleep behavior and social participation. And there were many, many findings in her work. The first one was kids with lower levels of arousal had greater sleep disorders. Remember, the parasomnias are sleepwalking, sleep talking, problems with bedwetting, that low level of arousal. Whether that manifests itself in our language as a passive response to that arousal or an active response to that arousal. We think about traditionally Winnie Dunn's definitions of low arousal passive strategy, low arousal active strategy, the passive strategy looking like Eeyore in Winnie the Pooh, and the active strategy of low arousal looking like Tigger in Winnie the Pooh. Both of these presentations may have an underlying low level of regulation in the neurochemistry in the brain. And these were beings whose chemistry and arousal levels were low in the daytime. And at nighttime, they would have sleep onset delay. Isn't it interesting that you'd have low arousal and problems falling asleep? There's a hijack of the transition into sleep. And more disordered sleep in the parts that I've just described. Challenges with sleepwalking, sleep talking, bedwetting. These are called the parasomnias. And so when you think about it, they don't have enough inherent energy inside their brain to manage the transitions. And so what Gila describes in her paper is that, in her hypothesis, is these kids need increased upregulation in their day life through their sensory experiences in order to be able to create a greater ease in their transitions in sleep. Okay? So the reason I bring that up in the previous slide is not because her work described the outcome of intervention. I knew that's what you would want to know. Is, does that actually happen? Her work was just to identify these correlations. Work on actually treating them is very limited in the literature. But seeing the correlations between the different sensory profiles and sleep regulation, that's where we're at in our current research in occupational therapy. There was a beautiful study in the Journal of Alternative Medicine looking at meditation and sleep for children and adults. And they found that this was very helpful, that it enhanced and guided meditations were very helpful for children. It enhanced the brainwave potential, boosted melatonin, increased REM, which, as we know, is critical, helped with serotonin production, reduced heart rate, increased heart rate variability, and decreased blood pressure. My gosh, we should all meditate. Now, these guided meditations can happen at any time. They can happen in the daytime and have this outcome at sleep, or they can happen at bedtime to support you in your transition to sleep. So meditation, as part of your sleep hygiene routine, has an impact on your arousal. Has an impact on your arousal at a very holistic perspective. It affects the default mode network in the brain and allows the cognition, the sensation, and the emotion to work together more optimally. Sensory interventions in sleep. I'm smiling fondly at this photo, which I took from the internet, of the Hip Hong Society, of the beautiful sensory environment that we use in our treatment. So here are a few findings about sensory processing and sleep disorders. Gila Spira said, greater daytime sleepiness was associated with tactile defensiveness. And she also found that taste and smell sensitivity, think about eating, was another hijacker of sleep. So as I'm starting to think about another course that we are creating called Eating Matters, Eating and Feeding Matters. So we have sleep matters, eating and feeding matters. There is an association here between sleep and eating. And it may have a common root in the taste and smell sensations that create an alteration in the brainwave activity and the activity of the reticular activating system as it supports the shifts in arousal. So that's very interesting. So tactile sensitivity and taste and smell sensitivity, they are behaviors that are highly correlated with sleep dysregulation. Chocat and her colleagues reported a relationship that was predictive between tactile hypersensitivity, as identified in the short sensory profile, and sleep habits. It seems like the touch system has a lot to do with how well I manage my arousal. That tactile sensitivity is a significant issue that may interrupt sleep regulation. Wojcik found that children who experienced challenges with tactile processing in her study were more likely to sleep longer without disruption and were less likely to experience daytime sleepiness. So that's a controversial finding compared to what I've just said in the other two studies. So it's important to remember that we don't, you have to look at all the different literature and that we don't have a standard, a gold standard, as we say, in understanding how sensations impact sleep. So just to say that again, in Wojcik's study, which was done in 2018, most recent one, children who experienced challenges with tactile processing slept longer in her study without disruption and were less likely to be sleepy during the day. So the opposite of what has been described in the two previous studies. Shani Adir and her colleagues Engel Jaeger, this study speaks to me because I am one of these people, that there is a correlation between eczema, atopic dermatitis, and this is in children and adults, by the way. They did two studies, one in children and one in adults. You'll see that in the reference list when you get to that. At the end of this series, that children who had eczema had higher degrees of sensory hypersensitivity in general, not just touch. They were more orchid-like. That really is so fascinating to me because the immune system and that sensory sensitivity, they're both sensitive. The immune system is sensitive and the sensory systems are sensitive. It's like a setup in my response to life. And what you see, and I mean, of course, the study considers the fact that you're itchy and scratching your skin, which can interfere with your sleep. But it also speaks to sensitivity to sound, sensitivity to movement through space, sensitivity to light, not just skin. So you'd think, okay, eczema, sensitivity to touch, I can live with that. Eczema and sensitivity to sensations. And what she found was a high level of sleep apnea, problems with breathing, problems with daytime sleepiness, energy management, sleep disorders, and sleep duration, frequent wakefulness in individuals with sensitivity. So this kind of speaks to the many clients that you and I support, but remember, both children and adults. So the use of touch as part of treatment is valuable. Deep pressure touch. We know that deep, and the reason I have a picture of somebody hugging themselves is we're in COVID-19, and so many of us cannot put our hands on people right now. So I wanted to emphasize how touch to the self. In the next session, I'm going to talk about Apollo neuroscience, which is about tactile cues through a device that provides these types of neurochemical shifts that you get through deep pressure touch that helps regulate your chemistry and fill your bucket with a greater degree of homeostasis at the level of your arousal system so that you have more capacity to manage your sleep challenges. So deep pressure touch, I would never call one thing a cure. It's like taking a bicycle wheel, putting sleep in the middle, and looking at all the possible interventions that I might need in order to support you as an individual. You can see how complex this is. I might need a sensory, a cognitive, and a co-regulatory strategy in order to manage my complexities of sleep. Massage. The work of Tiffany Field. Her book, Touch, written in 2014, is all the research of the impacts of deep pressure touch on many functions: pain management, growth, anxiety and depression, being able to self-regulate, but also on sleep, and how a massage, even if I have a massage at 2 in the afternoon, it will have a greater impact on my shifts to transition to sleep that night. So massage decreases cortisol, increases serotonin. So it brings you into a container of greater capacity for self-regulation, which can help me get ready for sleep.